Okay, guys. So before we talk about management, let's quickly talk about differential diagnosis for an epigastric pain. So differential diagnosis for a or of an epigastric pain. There's a lot, guys. There's a lot. There's a lot. So when someone's got epigastric pain, we are gonna think about gastritis. We are gonna think about esophageal. Let's start with we are going to think about peptic ulcer disease. We are going to think about esophageal ulcers. Esophageal ulcers or esophagitis. We are going to think about pancreatitis. We are going to think about cholecystitis or even cholelithiasis. Let me say gallstone disease. Gallstone disease. The list goes on. The list goes on. There are even some have even put pneumonia there. Some have even put dissection of the aorta, things like that. But the most common ones would be PUD, gastritis, esophagitis. The difference here would be that the patient is going to have pain as they swallow, as much as they might have some kind of epigastric pain, but at the upper pole of the epigastric pain, they will have pain as they swallow as well. Even esophageal spasm can give you. So these are the things. So if a patient doesn't, if you put a patient on treatment for peptic ulcers, they came with epigastric pain, and then you put them on treatment for a peptic ulcers, but the pain continues, think about perforation, think about hemorrhage, think about pancreatitis, think about gallstone disease and biliary tract disorders as well. Okay, so what is the treatment? So that patient that comes in with complications, that one you need to stabilize them and refer them to the surgeons. Just research them and talk to the surgeons. Like I said, when you have got an uncomplicated ulcer, you won't need surgeons there. The only time you might consider sending a patient who has got uncomplicated ulcer to a surgeon. Okay, let me try to write it down. So uncomplicated peptic ulcer, there is no immediate need to go to the surgeons. But when will you refer this patient to the surgeons? When you want an upper GI endoscope. Let's say you think it's an ulcer, but you want to rule out other causes as well, or you want to do a biopsy, or the ulcer is recurrent. You want to send them for a G-scope, or the ulcer is resistant to treatment, or they are not having any, there is no response, or which is resistant, so they are not having any response to the treatment that you have given. So you might want to refer them to the surgeons. Other than that, patients with complications, they have to go to the surgeons. So as interns, one thing that I try to do in all departments that we rotate in, I try to keep about 2 contact numbers from each department, so that when I stuck somewhere, I can always have someone that I can just quickly call for advice and all of that. So you call your friend there who's a surgeon, So for the complications, what you want to do, you want to stabilize them, because the fact that you've got complications, they might come in unstable. So you want to stabilize them and then refer to the surgeons. There's nothing you're going to do about it. Perforated ulcer, there's nothing that you're going to do except just to stabilize them. About a hemorrhagic ulcer or a gastric or a gastric outlet obstruction. What you can do is treat these ones uncomplicated. Peptic ulcer. How are you going to go about it? Someone who comes in they're in pain, they are vomiting, they've got nausea and all of that, they can't take your oral medication. What you want to do is, first of all, what I normally do, I put up an IV line, be it a normal saline or Ringer's lactate, and then give them a PPI IV. A PPI of choice you can give, we are going to talk about PPIs. You can give lansoprazole or pantoprazole. IV, and then you give them maxolone for nausea and vomiting. Don't worry about those at this point, but it's 10 milligrams. These ones are usually about 40 milligrams. And then you give so you give them that, the maxolone, and you can give them a painkiller. You can give them tramadol because they're in pain. You can give them tramadol IM. Buscopan will not help much, but you can give them if you want. So that's what you want to do there. The main thing that is important here is the PPI. We're going to talk about the PPI right in a moment. And then this is to stabilize them, to take them out of that pain. Once they become better, they can start talking and eating and feeling generally well. You can discharge them. If you've got access to an endoscope, you can refer this patient for an endoscope. But I mean, surgeons are busy. They wouldn't want to just to do an endoscopy. Just maybe if you're in private, you can send them for an endoscopy to see how the ulcer is and all of that. But sometimes when you treat a patient for peptic ulcers, they become fine, and then as long as they can identify the triggers and then they stop whatever that is triggering their ulcers, then they go home, they become fine. They don't need an endoscopy. But like I say, if you're in private and maybe your surgeon is bored, they want to do something, you can send them, but it's not a must that you send them. But if they come back again, like I said, resistant or recurrent, then you might want to say, okay, let's do an endoscopy. But patients that are having a perforation, they're having an obstruction, they're an gastric outlet obstruction, they will need endoscopy. These ones will need an endoscopy, but these ones not really. So when you discharge them, you're gonna put them on what is called a triple therapy. Triple therapy comprises of, you give them a PPI of choice. It depends where you are, but here we use omeprazole. I think it's the most common. Omeprazole for about 14 days. It can be 10-20 milligrams going up. So you give a PPI, which is a proton pump inhibitor. Okay, so when you have in our stomach, we've got an acid here. So one of the problems is a lot of acid. When you've got an ulcer, you want to try and neutralize your acid through your bicarbs. Now you also want to reduce the acidity of the environment there, because the more acidic the environment is, the more damage is going to happen when it comes to eroding the ulcer. So you want to reduce the acidity. So the protons. Remember, a proton is a H plus, is a charged hydrogen ion. So, and we know that by definition, acidity depends on the concentration of protons. So the more protons you have in a medium, the more acidic that medium will be. So so we know that those parietal cells, they secrete protons into this medium. They secrete a lot of protons into this medium because we need that HCl there. We need it. It's protective, but we don't need it we don't want it to start injuring ourselves. That's why you've got the bicarb. That's why you've got those defense mechanisms there. But now, so what you want to reduce the acidity of the stomach. So what you want to do is to block those parietal cells from secreting protons into this medium, creating this more acidic. That's why they're called proton pump inhibitors. All the lansoprazole, omeprazole, pantoprazole, lansoprazole, the zoles. So many of them are PPIs. So, and on top of this, you need to give the patient 2 antibiotics. And the reason why you give them 2 antibiotics, the 2 antibiotics plus 1 PPI makes that triple therapy. So, because you want to eradicate H. pylori. And the antibiotic of choice is amoxicillin, amoxil, and clarithromycin. Handwriting is so bad. Omeprazole, amoxil or amoxicillin, and clarithromycin. So you give this 1 gram for about twice a day for 14 days. This one is 500 milligrams twice a day for about 14 days. That's the first option. So it's called a triple therapy or H. pylori eradication therapy. Like we said, that patients who've got ulcers, majority of them, they've got H. pylori infection. Since we don't test everyone for H. pylori, so it's recommended that we give them the eradication anyway. So, and we said that as long as someone has got a H. pylori infection, they will continue to be symptomatic for peptic ulcers. So we need to eradicate that H. pylori there. So so that's why there's this concept of triple therapy, right? And we know that the longer you have H. pylori infection, it has also been implicated in gastric cancers as well. So you don't want that. Another option is to give a PPI, amoxicillin plus flagyl instead of clarithromycin. That's the standard. Those are the 2 standard first-line therapies. There are second-line therapies, which I'm not going to go into now, where you use bismuth and all of those, and levofloxacin, all those things. I'm not going to go there. That is at a specialist level. So for our level, we need to know that there is this thing called triple therapy. Okay, so what are the ways in which we can test for H. pylori? This is all theoretical. Never seen it being done. I don't know who does it. But I think because the guidelines, they know that not everyone has got access to testing this, facilities to test this. So eradication therapy should be given to all patients who've got peptic ulcers. So the ways in which H. pylori can be tested: there is what they call a UBT, urea breath test, and also there is a stool antigen test. Not even in Pretoria I had this thing being done. And also biopsy. I was surprised that you can even biopsy. So you can biopsy the tissues, and those tissues will have presence of evidence of H. pylori. So those are the 3 ways in which you can test for H. pylori. So I think we're done with ulcers, guys. If you've got any questions, you've got any clarity, you've got any comment, you can just drop me a comment there, then I'll look at it. But I think this is sufficient. Okay, one other thing that I'll just do for the sake of the students is the forest classification. I'll do it on another video. But basically the forest classification, I know the consultants, they like asking it. Like, guys, as a GP, I don't really care about forest classification. Someone who should care about that is someone who's a surgeon, because it's them who make that diagnosis when they do the endoscopy. They classify. If you take a patient for endoscopy, they've got ulcers, they will look into the ulcer and tell you what forest it is. And for me, that's not really important. I'm not going to be a surgeon, but for the sake of the students, we are going to talk about the forest classification. It's there are other classifications, but the most commonly used one, the most commonly asked classification for ulcers is the forest classification. We're going to talk about another video.